Good morning, dear ladies and gentlemen. Good morning, all the guests and the organizers. My task today is to speak on the importance of networks in cancer care at the international, national, and regional levels. My name is Tit Albreht. I'm from the National Institute of Public Health of Slovenia. The idea of networking in healthcare is not a new concept. Some health systems traditionally have decentralized organizational models. And of course, Italy is a very good example of that. The decentralization of the organization of healthcare and its financing, including the hospital infrastructure, is very well known. So the model of networking also at the national level and at the regional level is not new. On the other hand, modern advances in healthcare require multidisciplinarity and multi-professionalism. This is, of course, a challenge in view of the previously mentioned decentralization. Sometimes you have to create structures that go beyond a region or sometimes even beyond the country in order to provide services and care for patients that may have rare diseases or that may have complex diseases that cannot be treated in a traditional or more conventional way. Networking can be developed in various modes. Spontaneously, which is an ad hoc process involving different otherwise independent institutions. Directed top-down, so then there is a guided process where it is the policymaker's decision to develop networks. And finally, there is a directed bottom-up, a process where benefits are expected on initiative from lower organizational levels upwards. Organization of cancer or oncological care has seen one of the most rapid advances in medicine and healthcare. Monotypological approaches from the past do not work efficiently anymore. So experiences overall show two main conceptual approaches. One is the centralized, or rather aggregated in a single institution, where comprehensiveness of a single entity is primary and central. The other is decentralized, where there is a distributive organization, often inherited from an existing organizational model. There are a number of national experiences with networks in cancer care. A number of European countries has different experiences with networks. I will mention Italy, of course. Italy is a good example of both development of comprehensive cancer centers as well as the networks. It was the late Professor Veronesi idea of the regional research and comprehensive centers together with the networks supporting them. This concept was heavily promoted, and these networks operate in all the Italian regions. Germany took a different road. Their networks are primarily based on tumor-specific principles. So they are based on organ specifics. Although it has been announced that in the past this may change in the direction of molecular-based networks for treatment of cancers that share the same molecular or genetics characteristics. In France, there were some actions, especially in the south of France, around Toulouse and in the area of Grenoble and Lyon, of regional networking. And finally, Belgium, it's interesting that there has been networking of hospitals in the city of Antwerp, where a rather fragmented network of hospitals which deliver cancer care was set up into a network in order to produce a stronger, a more organized provision of cancer care. I should mention, because I was coordinating 3 joint actions, projects of the European Union and the member states, which aim at developing solutions and informing policies, both at the EU level and at the member state level. The second of these three projects was called Joint Action Cancer Control. In brief, we sometimes call it also CANCOM. One of the work packages was developing an approach to defining the networks at the EU level. Actually, this work package was led by the Oncological Institute in Florence, or the Oncological Institute of Tuscany. We developed the following 6 elements that define the networks as we understand them. I should just explain the abbreviation. The CCCN stands for Comprehensive Cancer Control Network. It consists of multiple units belonging to different institutions dedicated to research, prevention, diagnosis, treatment, follow-up, supportive and palliative care, and rehabilitation for the benefit of cancer patients and cancer survivors. You can see that we envisage a network that goes far beyond only immediate care, but also includes research, it includes screening, it includes survivorship. These units interact and have a formal agreement to work together in a programmatic and structured way with common governance. This has been pilot tested in 3 environments so far. One is the Comprehensive Cancer Control Network in Moravia, in Czechia, in the Czech Republic, with a center in Brno. The second and the third were part of our last project. One is the network developed within the Comprehensive Cancer Center of Charité in Berlin. And the third one is the Comprehensive Cancer Control Center in Lower Silesia in Poland, with a center in Wrocław. Within the CCCN, the care of patients is the responsibility of interprofessional teams that are multidisciplinary and tumor-specific. Each team or tumor management group works together for the benefit of patients with that particular type of tumor. So they still work together across different teams. There are uniform standards of care for cancer-specific pathways. This is another element that I need to stress. Patient pathways are essential for good management of cancer care. These are also binding the entire network. Finally, the CCCN promotes a uniform system of quality assurance and a unified informatics system for optimal exchange of information and reporting. The objective is to provide comprehensive cancer care to all the people living in a certain geographic area, thus pursuing equality and the improvement of outcomes and quality. This concept, of course, is very well known to my Italian colleagues, to also many of you participating in this conference. So I don't think there's much more to say or add to this. We can see that there are different examples of the so-called hub and spoke models. There are models that relate to healthcare, to public health, philanthropy, and others. We always have a range of services as these spokes around a specific or a particular hub. So this is something maybe closer to what we envisaged as a CCCN. Combination of primary, secondary, even tertiary care, services that support patients, as you see on the top on the right, continuing health needs assessments. Patients have different issues, psycho-oncological problems, psychosocial challenges, a reincorporation into their work or pre-morbid living situations. Sometimes this is difficult because they have been made handicapped due to treatment, etc. An example of hub and spoke models is also Ireland. Ireland is a country of 4.5 million inhabitants. And as you know, or usually regional models are envisaged for the sizes of the population between 3 and 5 million people. So there are 9 designated cancer centers. As you see, 8 are adult, 1 is pediatric, and each of them has this hub and spoke model. There are 26 sites administrating systemic anti-cancer therapy. So this is just the pure administration. For that, you don't need an entire hospital, or necessarily you need a well-equipped and well-staffed unit. So it is one of the potential concepts. I mentioned Tuscany already. Tuscany has actually several levels of these spokes. So there is not only, and of course there are 3 hubs, as you probably know very well. There are Florence, Siena, and Pisa as these big dots, and then there are 2 levels of these smaller dots. This is partly due also to history and partly due to geography of Tuscany because of the mountainous ranges in the north and in the east. But nevertheless, this incorporates also smaller units. What I need to stress is, of course, that these units do not really act independently. They are part of the same system. They have to follow the same criteria, otherwise they cannot be part of a network. Slovenia is also, even though it is a much smaller country than Ireland or Tuscany, we have a hub that is the Institute of Oncology in Ljubljana. There are big spokes, both university medical centers. There is a clinical hospital in Golnik, used to be a tuberculosis hospital. Now it's a comprehensive lung cancer center. So there is diagnostics, medical, radiotherapy, and surgical treatment of lung cancer all on that site. And then there are 2 smaller oncological departments in regional hospitals which serve as secondary treatment centers. Example of a tumor-based cancer network. I already alluded to this in the previous slides. They are networks based around the organ-specific problems. So there is a breast cancer network, there is a prostate cancer network. What are the advantages? Same problem, higher volumes, dealing with stratification. For example, you can explore breast cancer in older women, in very young women, outliers, specifics. It's easier to organize because people focus on the same problem, and they can focus also on a big number of nuances in treatment. There are disadvantages, maybe fragmentation of bigger centers if there is not efficient collaboration, focus on organs instead of cancer biology. European reference networks. European reference networks were an initiative of the European Commission to stimulate advanced research through supranational networks on related problems. There is one ERN for adult cancer and one on pediatric cancers. It's an excellent idea and promises to support smaller countries and environments and bring patients and professionals to the same footing. It is expected that the European Commission will commit more financial resources because they cannot function only on competitive funding. Europe's Beating Cancer Plan builds on all these different experiences and brings to the top of the agenda the European EU network of comprehensive cancer centers. This means institutionalizing the existing networking, formally organized within the OECI, and to upgrade it with a more stable organization and certification structure. We are not criticizing the existing structure. We are trying to upgrade it, standardize it, and make it really enacted as a European EU-wide format. This will be the core of the forthcoming joint action on the network of CCCs, which is expected to start in October 2022, and I will be leading its scientific coordination. Finally, my conclusions and final thoughts. Europe is a very varied organizational environment. There is no one-size-fits-all, and consensual adoption of new organizational formats seems warranted. Networking is a reality, so we cannot build our services and our delivery of care only on centralized institutions. This does not exclude other organizational formats, such as the CCCs, which we need for the research, education, and training purposes, which cannot be delivered always sufficiently successfully within very dispersed networks. CCCs are the core of networks, are the core of the high-level, high-end oncology, which will always be the leaders within the countries and internationally. I would like to thank you very much for your attention. Grazie mille. And thank you for your invitation, patience, and following of this presentation. Thank you very much.